Okay, we've just had the last of our 6 workshops. We've been thinking about workforce transformation, and we've decided that we'll get together as a panel and just think a little bit about some of the reasons why simulation and modeling are important in the current context. To help us with this, we've got a number of experts. We've got Douglas McKelvie, who runs his own consultancy in simulation and modeling. We have Holly Reid, who is a workforce transformation manager from Brighton. We have Charles Alessi, who's a GP now working as a senior advisor to Public Health England. And we have Peter Lacey, who also is a consultant simulation and modeling expert. So our first question is, with the most modern healthcare systems, why do so many people wait so long for service?
We have an aging population, increasing multimorbidity, and on that you need to factor the fact that Western medicine manages people by body part. So as people get older, there are more body parts. As there are more body parts, inevitably there's more to do.
The other observation to make in terms of waiting times is that in using systems language, they sort of reinforce themselves in that a waiting time is quite easy to generate, but far more difficult to reduce, because you've created behaviours within the system to refer to a waiting list, etc., etc. And it's partly a reflection of the metrics, but it's partly a reflection of human behaviour.
When people from outside healthcare describes the challenges, particularly if they come from an engineering or mathematical background, they lay a lot of stress upon variation and complexity. What do we mean by variation, and what do we mean by complexity?
The interconnectedness of it makes it challenging for people to understand, including the people who operate it.
As a workforce transformation manager, the variation that I most experience with regards to modelling or service redesign would be the variation in roles across either just trusts or organisations, or geographically as well.
We've thought about the challenges of intervening too early with people. You create lots more activity, not all of it necessary. Clearly there's a big problem if people have waited too long and we can't intervene until the last minute. So the really important question is, how do we intervene at the right time?
I think we need to be very clear that the amount of resource we have is the amount of resource we have. Hence, the time we intervene needs to be sensitive to the amount of resource we have. We know of stories associated with stenting, for example, when it was said that at one point there's enough bits of stent to build an Eiffel Tower, should one choose to. Because if you go in and have a look at people's arteries at whatever age, you could always say, well, you know, why don't I? Why don't I stop something happening which could happen in the future?
What is it that we really want from our health system?
For me, the ideal would be that you have the extent of care that you need and no more above. So, for example, if we're talking about end-of-life care, people don't really need to be in hospital at that time unless it's absolutely necessary. They don't necessarily need to be in 24/7 care home. What they need is to be comfortable and occasionally checked in on. So, for example, you've seen the amazing examples of hotels that have got intermittent care for residents, and you completely remove the plug that is stopping people leaving hospitals and, for example, care homes being completely full up. You take that away and it's just efficient realignment in terms of workforce, care and right place, right time.
Now we need to think about a whole integrated primary and community service that actually consumes as much and only sort of calls in the specialist as and when necessary, which is a very different way of thinking. It's not a sort of door into somewhere, it's a door that moves, sort of enters you into a horizontal world, if you like, of alternatives and different ways of supporting.
So we have some idea of what we want. What are the challenges of getting there? What's stopping us at the moment from getting to the system that we want?
Organisations will contact us and say, how do I balance my capacity so that my waiting time is exactly this number of weeks? And of course, the answer is, well, you can't do that. You either have enough capacity or you don't. If you have enough capacity, then you wouldn't need anyone to wait. And if you didn't have enough capacity, then the waiting time will always be increasing because there's always more people arriving than departing. It's more complicated than that, because then we've got how people behave and how people cope. But the key point there is that it's possible for somebody to ask a question that doesn't actually make a great deal of sense.
The way the system is set up doesn't incentivise activity leading to the sort of hospitals we want. So we want services that all link up together and serve people in the most efficient ways.
Okay, so one of the problems is that the systems that are used to pay for the services automatically shape certain behaviours that you're actually trying to change, but it's difficult to do that when you're incentivized in the opposite direction. Is that fair?
Yes.
Okay.
Just reflecting on the way in which we do strategy and change in the health service, which I've seen for 25 years or so, which is a preponderance of incrementalism, which is typical of a bureaucratic organisation, of which the NHS is an archetype. That will not help us get to a new world, if you like, or a new balance.
It's very, very clear that a population health accountable care type approach needs to be fundamentally different in the way it's designed than what we have at present.
The Cumberland Initiative has emphasised the importance of simulation and modelling in designing new services. Why is it that we're so passionate about this approach, and what is it that we expect to gain from it? So
I don't think I've found a better way to sort of engage with some of the questions that were asked, other than using modelling and simulation, when there's the need to sort of balance the quantitative with the qualitative, when there's people with an understanding of bits of the system but not all of the system. And what buzzes me into is that almost every time I do a project, I see light bulb moments in other people.
In this particular model, we paused and somebody said, so let's try a huge increase in admission avoidance service here. And so they did it quite a wild increase in that. And we ran the model again for a few more months, and immediately the delayed discharges shot up. And that wasn't what people were expecting to happen. And I was completely puzzled for a while. And I'd built the model until it became clear that there was an explanation for this, which was that so much energy was being put into admission avoidance that lots of people had to be assessed for their admissions to be avoided, and they were being assessed by the same members of staff who would normally be assessing people for discharge.
I think the biggest contribution that modelling offers is the conversations it aids and starts with clinicians. So just by planning and having a face-to-face discussion, it's quite hard to see how things could work, and you often get people turning around saying, that's never going to work, I can't see how that would pan out ever. By having a model, it gives you a process and an end result that might not necessarily be correct, but it's a conversation starter.
It can give you some start of an answer when you're in a complete fog. And very often when you're talking about some significant policy changes, you really are in a fog in terms of where it could go.
Well, thanks very much then. So we've thought a bit about how by using some of these tools we can get insight, and sometimes we can get the courage to take the next step in our design. And one thing is for certain, we're going to have to design our services in future, not just improve them from where they are.